I'm Dr. Ann Curtis. I am the Charles and Mary Bauer Professor of Medicine and the Chair of the Department of Medicine at the University at Buffalo in Buffalo, New York. I just presented a paper at the International Academy of Cardiology Annual Scientific Sessions 2015, the 20th World Congress on Heart Disease held in Vancouver. My topic was left ventricular reverse remodeling with biventricular versus right ventricular pacing in patients with AV block and LV dysfunction. And these were findings from the BLOCK-HF study. So first of all, we had a large multi-center national study that was sponsored by Medtronic, whereby we took patients who have atrioventricular block and therefore need pacemakers, and who also had some degree of left ventricular dysfunction that was defined by an ejection fraction of 50% or less. Now these patients all require pacemakers, and so normally they would get right ventricular pacing along with the right atrial lead if appropriate. We know from previous studies, however, that chronic right ventricular pacing can actually lead to deterioration of heart function over time. So the hypothesis of the study was that if we put in an additional lead on the left side through the coronary sinus and pace the patients through both the RV or LV and LV, or in other words, biventricular pacing, that outcomes would be better compared to right ventricular pacing. Now the main study had a composite primary endpoint of mortality, heart failure related urgent care, and or at least a 15% increase in left ventricular and systolic volume index. Now the study was positive and it had a 27% relative risk reduction in those endpoints. The paper I presented at the IAC meeting was about the echo endpoints. And so we did echocardiograms, transthoracic echocardiograms on these patients at the time of randomization and then every 6 months after that through the end of the trial. And we measured quite a number of different parameters, including LV volumes and size, ejection fraction, etc. Our findings were that if you looked at the LV end systolic volume index or the LV end diastolic volume index, that there was favorable reverse remodeling, or in other words, the ventricles got smaller with biventricular pacing, whereas with right ventricular pacing, there was either no change or the patients got slightly worse. We found that the LV ejection fraction increased by about 3 percentage points with biventricular pacing, whereas there was no change in the patients with RV pacing alone. In addition to that, we looked at the percentage of patients who had at least a 15% change in the LV end systolic volume index at each time point with both biventricular as well as right ventricular pacing. And at each time point, 6 months out through 24 months, there were many more patients who had favorable LV reverse remodeling with biventricular pacing compared to RV pacing alone. The final analysis we did was of the LV end systolic volume index as a predictor of outcomes, and we found out that it was actually quite good. So if patients had favorable reverse remodeling, then they had a lower incidence of mortality and heart failure hospitalizations. So in conclusion, what our study showed was that we do get favorable reverse ventricular remodeling with a biventricular pacing compared to RV pacing in patients with AV block and left ventricular dysfunction. And all of this leads to our recommendation that in such patients who need permanent pacing and therefore must be paced most of the time, that they are better off if they receive biventricular pacing devices rather than RV pacing alone.